afternoon and welcome. Thank everyone for coming, especially considering how beautiful it is and you're down here sitting in the basement with us, so we appreciate you being here. My name is Susan Williams and I am a member of the steering committee for Indivisible Cortland County, and I'm also a member of ICC's healthcare work group. And where is she? This is Sue Marks, who is also a member of the healthcare work group, and Sue and I are going to be co-facilitating the forum today. So before we get started, I just wanted to take a second to point out the exits. You can exit the way you came in here. The door over here on this side, you can go up the stairs and exit, and also at the back of the room there. And if you're looking for the restroom, at the back behind you here is the hallway to the ladies' room, and out this door here is to the men's room. So there's also set up coffee, hot water for tea, ice water, snacks. Anybody's help yourself to refreshments anytime that you would like to. So we want to get right to our presentation because obviously we have a great panel lined up for today, but we wanted to just take a minute to talk a little bit about Indivisible Cortland County. So who here today has attended one of our meetings or forums before? Great. So a lot of you have been here before, but it looks like there's some people that this is your first time. So for those of you who've been here before, bear with me. We're going to just go over a little bit of information you might have heard in the past. So we started out back in January with just 6 of us around a table in a local library. And after a month of just a few word of mouth invitation meetings, we had our first big public forum in February. And we had about 200 people here in this location, although I think the occupancy is 180. So we had 180. And at that meeting, we offered an overview about the rapidly changing scene in Washington, and we kind of highlighted healthcare, finance reform, and the economy. It was a little bit of a mishmash of everything. Then in March, we had another forum here, and the topic that month was immigration and agriculture. It was also very well attended. Last month, we moved to Center for the Arts for 1 month, and we focused on the environment and had a presentation about the importance of honeybees. So if you kind of notice, there's a little bit of a theme. So this month, our topic is healthcare, which is why we have the Healthcare Forum and our wonderful panel up here. Between these monthly events, our steering committee and our work groups have been busy keeping us all informed and, holding various smaller community events or participating in community events. And also, since we started around that library table, 6 of us in January, our active members have grown to over 150. Our email list has grown to over 180. We have over 400 people following us on Facebook, and we have over 1,500 people following us on Twitter. So, we're really kind of pleasantly surprised at how quickly that this has grown, and we really appreciate all of the support from all of you and the rest of the community, and we hope you'll continue to stick with us. So, the one thing that we've done every month at these meetings is to give a brief testimonial. So somebody local who identifies with the work that we're doing and has personal experiences that they'd like to share. So today I'm happy to introduce Karen Dudgeon. She's going to play that role for us. And Karen is a native of Homer who returned to our community to raise a family. And she's a licensed clinical social worker with a full-time mental health counseling practice in Cortland. She's a wonderful wife and an amazing mom to 3 terrific kids. And Karen not only sees firsthand through her job some of the issues with healthcare that our panel is going to speak to today, but personally she carries her own health insurance for herself and her family through the ACA. So if we could give a warm welcome to Karen.
Oh, that's tough. First of all, I just want to say thank you to all of you. I saw who was coming today and I was like, holy cow, I can't believe they got all these people. That's fantastic. So thank you. So I'm Karen, it's nice to meet you. And I'm a therapist, so we don't usually talk about ourselves. So this was a really big challenge to me. And I was ranting on Facebook one night and Susan took advantage and said, hey, why don't you come to our meeting and talk? So I'm a little out of my comfort zone, but I could stand here and tell you story after story about how people's health care plays out in terms of mental health in the community, particularly folks with really high deductible plans who think that they're able to save a little bit that way, but then when a mental health crisis hits, those bills add up really quickly. And so that's something to think about as we're having these discussions, particularly given that many mental health diagnoses are included as pre-existing conditions under the new law. But really, the reason why I'm here today is that I'm not here by myself, and I am, but I'm here for my family. I have my husband and I carry our health care through the Affordable Care Act. My husband is a private contractor. He works in theater, and I own my own business, so we don't have another option. And we have 3 amazing kids, 2 of whom have pre-existing conditions, and one of whom is the reason why I got brave enough to come up here today. My son Declan is 5, and he has a rare and new diagnoses, which is the double combo for, oh my God, what are we gonna do? Called eosinophilic esophagitis, and he gets sick a lot, is the short of it, but it also creates some other health issues. 2 months ago, he was wheeled in for some exploratory stuff in his stomach and esophagus with 6 specialists, 4 nurses, 2 PAs, and those were the only ones that I actually met. And as a parent, I was absolutely terrified that day for my son, for what this was going to mean for our family. But really, the thing that I didn't have to worry about that day was that this procedure was going to be covered, that we knew exactly what it was going to mean for us financially. And so I didn't have to factor that into, am I going to get my child the best care? And so I just want to say to all of you, thank you so much for coming here and being part of this, because this is such important work. And I know it's scary. I was a little intimidated by coming. And I actually spoke with a colleague yesterday who I know professionally, but called me up, and he said, we don't know each other well personally, but he was like, so I'm kind of part of this group, and like we're doing some stuff about healthcare, and I don't know if you voted for Trump or not, but so there's a lot of people who are not necessarily publicly out here with this. And so spread the word, because I think healthcare is really one of the lightning rods that I think that we can come together with and bridge the gap between parties and political philosophies. So thank you very much.
Thank you, Karen. That was great. So my name is Sue Marks. And before I introduce our healthcare panel here, who thank you so much for coming today, I just wanted a couple of little quick things. We have a display board in the back about healthcare issues, and we have some index cards there to write to your New York State senators, personal stories, some of your concerns. So there's a whole bunch of stuff back there. Susan will talk a little bit more about that too later on at the end. And we also have index cards. I don't know if people already have them or they're being passed around for during our panel, because our panel, how we're going to work this today is that each panel member will speak 5 to 10 minutes. The Lisa claims she'll only speak 4.5. So I don't know, we'll see. Ms. Mason. Okay. And so we're going to let everyone speak, and then at the end take questions and comments and that kind of thing. So if you're thinking of things during one person, you can write it down quick. So our presenters will be speaking about healthcare topics here. The Affordable Care Act, what went well, what doesn't work so well in that, what some suggestions, that kind of thing, in Cortland County, our gaps, our needs around here. And any thoughts on the American Health Care Act that's been passed in the U.S. House of Representatives recently. And then also, right in New York State, our New York State Health Act, which recently passed in the Assembly. In a little bit, there'll be some information about that. So, I'll introduce our lovely panel here. So our first person to speak will be Lisa Herschel. She's the Executive Director and CEO of Family Counseling Services of Cortland County and Family and Children's Society in Binghamton. She has a master's degree in public administration from the Maxwell School of Citizenship and Public Affairs at Syracuse University. And then after her will be Denise Rinn, and she's the Vice President of Finance and Chief Financial Officer at Cortland Regional Medical Center. She has worked 28 years in the healthcare finance area, with 22 of those years right here at Cortland Regional Medical Center. And she has served 6 years as VP of Finance, CEO at St. Camillus Rehab in Syracuse. Then Doug Ronner, and hopefully he won't have to be called off to the nursery at the hospital.
I'm on call.
He's on call, so hopefully we'll get through him too. But he's a family physician, the vice president for medical services, Family Health Network of Central New York, and a clinical assistant professor of family medicine, SUNY Upstate Medical University. He has served on the Cortland County Board of Health for the past 8 years, and it also has held several leadership positions at Cortland Regional Medical Center. He is a recipient of the Rural Health Practitioner of the Year Award from New York State Association for Rural Health, as well as Cortland Regional Medical Center Physician of the Year Award. Okay, and then next to him is Bob Haight, and he is the president and CEO of Cortland County Chamber of Commerce, and this is his 8th year at the Chamber. And for the Chamber, it's their 4th year of helping individuals, small businesses navigate the ACA. They have 3 trained navigators on staff and have had thousands of navigator appointments. And then finally will be Linda Smith, and she has worked for the Assemblywoman Barbara Lipton since 2004, and is currently her chief of staff. She graduated right here at SUNY Cortland with a degree in chemistry, and prior to coming to work for Assemblywoman Lipton, Linda worked as an occupational health and safety trainer for the local nonprofit Mid-State Council on Occupational Safety and Health, and the Central New York Council on Occupational Safety and Health. She's an active member for the Mid-State Central Labor Council for 20 years, serving as a president, and she's also a local resident and has a farm right outside of Marathon. So, a lot of credentials here. That's hard to get through. So, take it away, Lisa.
I just want to do a super quick commercial for United Presbyterian Church. I'm a proud Presbyterian. I'm really proud of our church for welcoming this group every month. They've been doing programming around issues that I think are important when it comes to diversity, when it comes to acceptance and tolerance all year. I think there's a reason that we're focusing on those issues this year in particular. Tomorrow there will be a celebration of immigrants in our local community. There will be music and food and lots of fun and stories at 3 o'clock here tomorrow. Really want to focus on the benefits that immigration brings to our community, and I'm hoping all of you will be there.
Upstairs.
Upstairs, in the sanctuary. We all talk about healthcare quite a bit, and we talk about it from philosophical perspectives. We often talk about it in terms of ideology, but really healthcare is a pocketbook issue that no one really has figured out how to make accessible for the people on the ground. We all know that it costs us money. We all know that what we're paying for is not health, we're paying for medicine. And that's what happens when you talk about money and when you make it about money, it becomes about money, not about health. And I think that's something that we need to remember as we have these conversations. We spend more than anyone in the world on healthcare and have some of the worst outcomes. More money is not going to help. So I'm here to talk mostly about the mental health and addictions aspect of changes in the ACA under the AHCA. And I will only speak briefly because you have a lot of really smart people here. And I'll tell you a little bit real quickly about Family Counseling Services and our sister organization, Family and Children's Society. We provide home health, mental health, and addiction services to over 10,000 people in 20 clinics in 4 counties, Cortland, Madison, Broome, and Tioga counties every year. We almost mirror exactly Claudia Tenney's 22nd district. For the past 5 years, Family Counseling Services and Family and Children's has seen a dramatic increase in the demand for mental health and addiction services because the ACA has provided increased coverage through Medicaid expansion and subsidies for insurance. Previous to the implementation of the ACA, many of those who would have benefited from mental health or addiction services did not have the coverage that allowed them to access those services. In addition, parity requirements under the ACA mean that healthcare and addictions coverage must be treated exactly the same as coverage for physical health ailments. That's been a very good thing for us. It means more people are getting more treatment and learning resilience in our community. Under the AHCA, a few things are going to change. Medicaid expansion will be rolled back. In New York State, that impact will be $4.5 billion. That's a lot of money. In the 22nd district alone, congressional district, 82,000 people are likely to lose their insurance coverage. 82,000 people in this region. In Cortland County, by the way, in our clinics, and in Broome County, 80% of our clients are being seen only because they have Medicaid or coverage through the ACA. 80%. Nationally, up to 24 million Americans could lose coverage. States can now seek waivers, or will be able to seek waivers from several consumer protections currently required to be provided under the ACA, such as Karen mentioned, pre-existing conditions. Lifetime caps could very likely come back. Reproductive health coverage could become non-existent in many of our states. I'm already hearing stories from friends in southern states who say insurance companies are already denying coverage for pre-existing conditions, even though that's illegal. Because health insurance companies believe they'll cut the coverage, they'll deny the claim, you fight it out. That's the way they work. Mental health and addictions disorders would be considered pre-existing conditions and would likely not be covered as they are today. Mental health and addictions are currently required to be treated the same as other health care concerns under the ACA. That's not a requirement on the AHCA. And states would also be able to charge the elderly and the sick, including the mentally ill and addicted, more for coverage. The elderly, by the way, of which I'm almost one, would pay up to 5 times more than other people. In our clinics, we've seen an explosion in the opiate addiction population, a 4-fold increase over the past 5 years, times 4 the number of people who are approaching us asking for addiction support because of opiates. This is not the time for Trump to cut 95% of the budget of the Office of National Drug Control Policy. 95% out of one of the most important agencies that deal with the addictions problem in our nation. I just want to say one thing about addictions, because people often speak about addiction as a personal failing that should not be treated as an illness. In fact, under Attorney General Jeff Sessions, we are moving backwards in that and recriminalizing addictions rather than opening access to treatment. Addiction, especially to opiates, must be seen through a different lens. It's important to remember that 60% of addicted people have underlying mental health conditions which are contributing to their substance abuse. 60%. 80% of the opiate prescriptions written globally are written in the United States of America. 80%. And 75% of overdoses are not heroin. They're prescription overdoses. This is an epidemic created by a pharmaceutical industry out of control. It's important to remember that addictions and mental health treatment is vitally important to our nation, to our children. ACA is helping people access those services. It may not be the best. There is no question that we need to find alternatives to some of the problems that the ACA is providing. But the AHCA is not the answer. And certainly having Donald Trump state that he's going to now be cutting insurance company subsidies will put the entire market into disarray. It's a concerning issue. I'm glad you're all here to hear more about it. Thank you.
Trying to get there without tipping over my chair. Hi, I'm Denise Rinn, and I do want to thank, Lisa actually contacted me and asked me if somebody from the hospital would participate in the forum today, and we weren't quite sure what the topic was going to be, so we kind of kicked it around, and when we realized what it was, it sounded like it had to be the Mayor Mark Webster, who is our CEO, and he couldn't be here today, so I'm it, so thank you for having me. I think, as you all know, Cortland Regional Medical Center is the only hospital in Cortland County. We have served this community for over 125 years. And I think the other important thing to know, not only are we a provider of service, We are the largest private employer in the county. The only other organization that employs more staff than we do is the college. So we see this from both sides of the fence, as a provider and as an employer who has escalating healthcare costs just like all of you do in either your personal policies or at your own employment. The hospital's vision is to have local access to high quality patient-centered care, and we strive every day to try to do that. And I think, when you look at how we serve this county, we provide over 108,000 visits a year to outpatients. We have almost 30,000 visits to our emergency room every year. We deliver almost 500 babies. We have an 80-bed skilled nursing facility, which has the best reputation in the county. So we have a lot of services, and I think people forget all the components that we have. And in addition, in the last 3 years, we have been building a very extensive medical practice in Cortland County. We've gone from about 15 providers to over 40. A lot of them specialties that we never had in this county. So when you look at how we operate, the system itself probably has gone through the most dramatic changes in the last 8 years, both from a clinical side and a quality side and a financial side. And they're trying to move the system from the more expensive institutional-based system where you end up in an emergency room, you go to the hospital, you're at a nursing home. What they want to have happen, and it totally makes sense and we agree, it really needs to be moving healthcare to a community-based organizations like Lisa's, to primary care practices like Doug's, like ours, to the home health agencies and things like that, because it is cheaper in that setting, and it's better for all of you to have the care and stay in your homes. I'll say this, we all know you go to a hospital, you go to a nursing home, it's very complicated, things happen, you can get infections there. You don't want to be in an institution if you don't have to be there. You want to be treated at home. So the system's been moving to that. And the government payers, so Medicare is the payment from the federal government who pays for elderly and disabled care. Medicaid is more for the low income. It comes through the state of New York. It's a 50-50 split between the federal government and Medicaid. Those are the government payers. At Cortland Regional in this county, 70% of the patients that we take care of are paid for by one of those two governmental sources. Our county has an elderly population. It has lower income population. It's an agricultural rural county. That's the mix that we deal with. Just from the hospital's perspective, for every dollar that we spend on one of those two types of patient payers, we get paid 80 cents on the dollar for a Medicaid patient. We get paid 90 cents on the dollar for a Medicare patient. So every time we take care of 70% of our patients, we don't even get paid what it costs us to take care of them. So over the last 8 years, there's been pressure, obviously, to lower what's being paid to the providers. So what happened with the ACA? The ACA, the big thing with the ACA was to provide insurance for patients that didn't have insurance, and also to protect patients. The real name is the Patient Protection and Affordable Care Act, shortened to the ACA and Obamacare, but patient protection is in that title, and there's a lot of things in there that affected not only those of you without insurance at the time, but those of us who had insurance at the time and still have it. And the way it was funded is really important. It was funded in two mechanisms. There was a lot of different tax things, taxes on medical supply companies, taxes on employers, taxes, there's a whole slew of taxes that went into pay. But one of the largest components that paid for the ACA was 20 years worth of Medicare cuts to the hospital system. So they took money away from the hospitals right up until 2020, so it still hasn't all happened, to help fund the ACA. And the American Hospital Association supported that, and so did the New York Hospital Association, because the thinking was, if more people have insurance, we'll have less people coming into our emergency rooms in the hospitals with no insurance, and we're totally getting paid nothing because we're writing it off as a bad debt. So there was a trade-off in how we got paid, and the hospital system agreed to that. So what kind of protections did you get from the ACA as a patient? Lisa talked about it. There was no more pre-existing conditions. There were no limits on coverage as far as $1 million limits. Your kids up to 26 could stay on the plans. There was certain essential coverage. So there's a lot of good things that all of us got under the ACA. And the Medicaid expansion, 32 states adopted the Medicaid expansion. And what that was, under the previous Medicaid, at 100% federal poverty level, you could get Medicaid. If you expanded, you could make up to 133% and get Medicaid. New York State has always been progressive. They led the way on that, and they did the Medicaid expansion. New York State put its own exchange in. They don't use the federal exchange. So the state, you're actually lucky that you live in New York right now, because New York is probably not going to let everybody fail under whatever happens in Washington. How they do it is yet to be determined, I think, and I think Linda's going to speak about that a little. But what did we see at our hospital? We saw a shift of our uninsured patients shifted to Medicaid. So when people went on the exchange, they didn't get the exchange products in Cortland County. A lot of them got Medicaid because they qualified. I think the biggest thing that we've seen, going forward is we have seen more coverage, and that's been very good, I think, for the hospital and for the medical groups. The AHCA is very scary, just as Lisa just said. They're going to eliminate a lot of benefits. They are not going to fund Planned Parenthood. I know there's been a lot in the paper about the Jacobus Center and the Planned Parenthood issues about what's coming out on that. No more individual and employer mandates. The scariest thing is the block grants. Medicaid right now is an entitlement system. And what that means is however the state designs their Medicaid program, the state pays half, the feds pay half. So New York State has a much more enhanced system than other states do. Under the proposed the AHCA, they want to have a cap, a per person cap. So however much, if let's say it's $10,000, for every Medicaid enrollee, they'll put in $10,000 and New York puts in whatever they put in. And that's it. So if the state wants to keep its enhanced program, they're going to have to kick in the money. And if they pay in more than the feds say they can pay in, they're going to penalize the state next year and pay them less. So this is a really bad bill that is down in Congress right now. As far as Cortland Regional goes, as we look at the way it stands today, we're slated over the next 10 years to lose over $13 million of funding under the current ACA, but at least we're getting insured people coming in our door. Right now, under the AHCA, we will lose that $13 million, and we will have all these uninsured people coming back into the medical centers. So I think that's a real big reason, community-wise, why we need to pay attention to what's going on in Washington. So thank you very much.
Thanks, Denise. Dr. Rana.
I got nothing.
Not a surprise.
I want to give you a little primer on what healthcare looks like and where the costs are. You heard that we spend the most on healthcare out of any country in the world. There was a recent study that came out in The Lancet, which is probably the most respected British medical journal. And it looked at 150 countries, looked at the health outcomes in those countries. US is number 80. Not so great. Okay? We're on par with Montenegro and Estonia. Okay, to give you an idea. Why is that? We're spending all this money on it. Okay? Where's our healthcare dollars go? There are a lot of different answers to that. But if you look at where the expenses are, the cheapest form of healthcare is self-care. Living well, living in a healthful lifestyle. There's not an accident why Colorado has the best health stats out of any state in the country, because they have the best health habits. They eat well, they exercise, etc. Okay? It's not that they have the best hospitals or the best doctors. Okay? It starts there. Then the next part of healthcare is primary care. That's what I do. I see patients in the primary care office. That's fairly inexpensive, okay? But when people access primary care, very often we can address issues before they become emergencies, before they become expenses. The next is hospital care. You access into the emergency room and then possibly into a hospital, and then tertiary care where you land up in a large academic medical center for real specialty care. The U.S. is number one when it comes to that sort of issue. If you have something weird or very dangerous, you want to be in the U.S. But if you're in the general population, you want to be somewhere else, probably, because the other countries do a better job of funding those less expensive parts of the system. We're in the process of shifting over to that. But in order for us to do that, people have to access care. When people don't have insurance, they do not access care. And when we saw the ACA come to fruition, we saw we're a provider of care for all income levels, and a lot of our patients did not have insurance. We saw that number of uninsured patients be cut by 2/3. Okay, it's now in the single digits of what we're seeing in our health centers, okay, which is huge. And now people are accessing care on a primary care level. So they're getting care and medication prior to them becoming really sick and landing up in the emergency room. We still have issues of patients not being able to afford care, and I'm not coming in because I can't afford the deductible. Because unfortunately a lot of employers are going toward high deductible plans as well as some of the products on the exchange. And when you have a high deductible, your first costs are out of your pocket, and some people are not accessing care. It's in that situation when these people land up putting off care, and then they land up getting sick and getting into the very expensive parts of the healthcare system. Okay, that was the beauty of the ACA, is that more people were accessing care over here where it was cheaper. Okay. And we're actually seeing some evidence that quality measures in healthcare are improving because of the ACA. Okay, so that's what I really like to pay attention to. Prior to the ACA, I had lots of patients who fit into this sort of category. Late 50s, they're working, they don't have insurance, they developed a health problem. Diabetes is a perfect example. Diabetes is very expensive. A lot of the medications are expensive. A lot of the testing is expensive. When you pay cash for something, you typically pay more for care than if you actually are part of an insurance plan. So these people often went without. They did not come for appointments. They had to pick and choose what medications they were going to be taking. And it was a challenge taking care of them because often you wanted to give them this medicine, they could not afford that medicine. And so we had to, well, what else can we do? It was a real challenge. And a lot of these people got sick and prematurely, unfortunately. And if you get the complications, say, related to diabetes, it's terrible. Amputations, blindness, etc. So that was the wonderful thing about the ACA. The new legislation, much of that would go away. And I fear for that because many of these people would lose their insurance. They would not be able to afford the products that would become available to them under the new plan. Okay. I want to talk about some of the issues that we see here in Cortland County. You've heard about the opioid crisis, which is a national crisis. It's a local crisis. I want to give you one stat. I was recently at a training from the Crouse NICU. They are the regional neonatal intensive care unit. They draw patients from 11 different counties, and they transport patients from Cortland Hospital to Crouse when we have sick babies. Okay. The number one reason why babies are being transported now to Crouse NICU is because they are going through withdrawal because their mothers were on opioids. That has become the number one reason why they're doing that. That's shocking. The littlest, the most innocent individuals are being affected by this crisis. And we cannot cut any funding at all. In fact, we have to redouble our efforts in order to combat this crisis. Okay. Lastly, I want to, since we have someone from our state assemblywoman's office, from a healthcare policy standpoint within New York State, I'd like to if we can possibly break down some barriers. Right now, we're trying to integrate services under something called district, which I won't even bore you with.
Don't go there.
Okay, all right?
Don't.
And one of the things that we're running into is that much of the state is still working in silos. Mental health and Department of Health and the state nursing board are not really on the same page when it comes to things. So when we want to institute integration, Lisa knows all about this. Integrating primary care and mental health and trying to do it, it's really, really hard, even though it makes so much sense because the state agencies aren't really working with each other. We also have an issue of trying to develop team-based care within our health centers, so everyone's doing different things, but in order to do that, nurses should be operating under some standing orders, but the state nursing board doesn't like standing orders for the most part. So it's made it more difficult to provide the care that a lot of other states are actually able to do, and because of old antiquated models of state government. So you can bring that to Barbara. Okay. I'm being told I'm running out of my time. So, but if you want to ask me questions later.
I have a question.
Well.
I heard that 6% more of American women within the birthing range, that the doctors that are for the baby, that they are not trained in the health care for the mother, and that we're the lowest in all the nations across the world of the mothers dying at birth because of not diagnosing a mother with preeclampsia, for example, or I forget the name.
Well, our infant mortality.
Yeah, you focus on the infant, but not on the mother.
You're right. Okay, I'm not familiar with that statistic. So if we can.
I heard it on NPR 2 nights.
Well,
Okay, so we'll give Dr. Ronner
Right.
a chance to answer that, but then if everybody could hold their questions till
All
the
right.
end, because we want to make sure we have a chance to
You
get to
got
all of our people.
Thanks for having me, and what a great group, and you've heard from some medical professionals already, so why am I up here? I think that our organization has two roles that play a part here. First of all, we work with 440 businesses and organizations who are members of ours, so we speak with them on a daily basis. So we have a lot of information. I'll share a quote here I had from one of our small business owners about how they try to provide health insurance and what their struggles are for doing that for their own employees. Then as our navigator role, we began actually 6 years ago working with the Affordable Care Act, so even before it was rolled out, as they were still writing it, we were one of the conduits from the feds to the states and then to us, and we worked with small business owners, simply giving them information about what it means and what you'll be required to do and how you'll be required to do that and what benefits are there for small business owners if you participate in the Affordable Care Act. Then when it officially rolled out and the exchanges opened 3.5 years ago, we at that time had 3 navigators already trained, so we were on board to help both small business and individuals who wanted to sign up. Because of our role locally with small businesses, that's really what prompted us to get into the navigator role. We wanted to help those small businesses who wanted to participate. What I'll say is 3.5 years later, we have now had thousands of individual appointments, and our small business portion of that really is almost exclusively information. So I can tell you who officially are working with us as a navigator, it's about 12 small businesses, where the number is in the many hundreds of individuals who are working with us. And there are some good reasons for that, and that leads me to this one quote that I'm going to give you. So this is from a small business owner directly, and obviously we won't use their name. Wrote to Nikki, one of our navigators. Thank you for taking the time meeting with me regarding the health insurance on the marketplace compared to our traditional insurance plans, in parentheses, where the company pays for the employee. I'm having a hard time gripping this concept that plans I buy for employees as a company that cost me over $1,200 per month are simply available to the employee on the marketplace for something like $80. I mean, this is a huge incentive for all employers to drop health insurance altogether and then give an employee a 46 cents an hour raise to go buy it themselves and get the same plan, while a tiny company like mine could save tens of thousands per year by not offering it. Quite frankly, the steps taken by the employer to offer a benefit seem to be a big, this is the way he put it, F you, if the state/feds are simply going to offer it openly at a 95% plus discount. Am I missing something here? And the reality is no, he's not missing anything there. That's what a small business owner is looking at this as. Because depending on your employees' income level, your employees are better off going to the exchange and buying their own insurance, and you can give them a raise and save a lot of money doing that. Now, this employer and many others are still offering their own insurance, and this note came out to us after the election. And so simply because of the unknown on what was going to happen with the Affordable Care Act, he said, I'm not at this point going to take away the benefit when we don't know what the employees will receive a year from now or 2 years from now. So, I mean, good for him. He wants to do the right thing and keep it up. And that's what we see from a lot of small employers. The expense of it is very difficult, but they want to do the right thing for their employees, so they'll keep offering it, even though, as you read, in many cases, they're better off taking subsidies from our tax dollars in order to help individuals pay for it. One of the things commented from one of our first speakers, New York State, we're lucky to be here, and that's true. I'll give you a little more evidence of that. So New York created our own exchange, and you may remember 3.5 years ago when the exchanges rolled out and there was a huge crash because so many people went to the exchange. That really was the federal portion of it that crashed. New York, while we had some glitches and some struggles to get through, overall we were in pretty good shape. So that was a great thing. If the Affordable Care Act is going to be here, having our own exchange has really been a nice benefit to us. Also, one of the things that we've seen here in Cortland County, we're a small rural county, but individuals going on the exchange still have 3 options of health insurance companies who are willing to sell them health insurance. The number is now up to 40% of the counties across the country that are down to 1 insurer, and they think that in 2018 there will be 8 states where the entire state will only be offering 1 insurer. So there's something broken there. I can tell you that health insurance in a single insurer county is 67% higher cost than a county that has 6 or more insurers being offered. So something needs to be done to get more competition. We need to go the right way there, and I think that's the struggle that all of us have, or what are the best ways to get to that point. I'll just take a second to thank our healthcare providers who are here, because another reason why we're lucky in Cortland County. Yeah, we're a small rural county, but we have great professionals here helping all of us. And I think you've already heard them say, nobody gets refused healthcare in this county. We want you to have insurance. In fact, it helps make insurance less costly for the rest of us if every single healthy person were to have insurance. But thank goodness that we have these guys here with us. So that's all. I'm happy to answer questions either about the small business side or our navigator role as we go on. Thanks.
Thank you.
Way down. Can you hear me?
Yes.
Okay. Hi, everyone. I just wanted to say thank you to Indivisible Cortland County for putting together today's forum, and also for all the great work you've done since the election last year. So, Assemblywoman Lifton would have been here today, happily presenting. She actually is outside today. She's up in Romulus talking about what New York State is doing to promote carbon farming and getting to see some of the demonstration, the techniques that we use for carbon farming. But I'm happy to be here as well. So we've heard from the other panelists about some of the good things with the Affordable Care Act, as well as some of our ongoing problems and weaknesses with our healthcare delivery system. Certainly there were strides made with the ACA. New York has a pretty stable exchange, better than most, fewer insurers dropping out. Our uninsured rate has fallen from 10% to 5% statewide. 3.6 million New Yorkers now get their insurance through the ACA. 2/3 of them are under Medicaid or Child Health Plus. That's about 2.7 million. Another 650,000 or so are enrolled in what we call the Essential Plan, which is a highly subsidized plan, and that helps people up to 200% of the poverty level. And then the remaining 300,000 actually buy private insurance plans, and 59% of them get a tax subsidy. They get help. So certainly we've done better than many states. The problem is our system is still controlled by insurance companies. They set the premiums, the deductibles, the co-pays, the network, the out-of-network costs. And if you have, say, Plan A, it does not matter whether you're a billionaire or a day laborer, you're going to have the same cost. So families are struggling to pay all those costs. It is very regressive in nature. It is not based on ability to pay. We still have 1.3 million people in New York who are uninsured. And so if they show up at the emergency room, we're still paying for that uninsured care. Last year, 2016, individual plans went up an average of about 17%. Small plans, small group plans went up over 8%. Better than the rest of the country by far, but still unsustainable and a huge burden on our families. We pay for insurance company administration costs, marketing, profits. Under the ACA, that was capped at 15%, but most of our insurance companies are pushing that right to the limit. In Canada, their administrative costs are less than 2%. Traditional Medicare, when you take out that private Advantage programs, those plans, is 1.8%. Healthcare providers, the hospitals, the doctors, they spend an inordinate amount of time and energy dealing with multiple insurance companies with different codes, different guidelines. They sometimes deny claims, and then you have to keep fighting to get your money. Our employers spend $2 billion in New York State managing and administering health benefits for our employees, for their employees. Healthcare providers also have administrative costs only because of the insurance companies. Administrative costs, overall administrative costs, account for 30% of total healthcare spending in New York State. Large companies actually are able to negotiate a smaller premium for their employees just by their size. And so small companies are hurt. Small companies, and I think Bob said that, who want to do the right thing and provide health insurance for their employees actually take a bigger hit than, say, some large multi-state companies. Workers' wages suffer. Money goes to pay for health insurance instead of going to our paycheck, pension, or vacation. So as we know, Congress and the White House want to repeal or defend the ACA. They do not want to fix it. So we're headed in the wrong direction from the federal government, and if we do nothing, it's going to get worse. There's a better way. It's called the New York Health Act. It is a single-payer universal health care system, improved Medicare for all. In the Assembly, it's A 4378, and in the Senate, S 4840. The single-payer system, the bill, was actually first introduced in the New York State Assembly by Assemblymember Richard Godfrey in 1992. It passed the Assembly in 1992. It has since passed the Assembly 3 years in a row, 2015, 16, and most recently, this past Tuesday, with a vote of 94 to 46, overwhelming support. Assemblywoman Lifton has been a sponsor of the bill since she first got elected in 2002, went into the Assembly in 2003. The bill has never made it out of the Health Committee in the Senate, but there's growing support. 18 to 20 months ago, yeah, year and a half ago, there were only 18 to 20 co-sponsors. Today there are 30. And I think that's reflecting on the increased support for a single-payer system, both in New York and nationwide. So we're almost at a majority. Professor Gerald Friedman from University of Massachusetts at Amherst has actually done an economic analysis of the single-payer system, and some of the things that I cite, the facts that I cite, are from that study. So, number one, everyone is covered, and the coverage is comprehensive. You have a freedom to choose your healthcare providers. No more restrictive networks. It would cover you when you're out of state, either traveling or if whatever you needed, whatever service or treatment you needed was only out of state. No more regressive and skyrocketing premiums, copays, deductibles, out-of-network charges. No more financial barriers to care. The cost savings, there would be cost savings on prescription drugs and medical devices. I think somebody mentioned how those prices are going up because of the bargaining power of the state. 98% of New Yorkers, that's everyone making less than $436,000, would pay less overall than they do now for health care. Our property taxes would be reduced. Why? No more local Medicaid share. That's about $7 billion statewide. And currently our local governments and schools pay for health insurance for public employees. That would go away. Now they would still have a cost, which I'll get to in a second, but they would not be paying for health care premiums and all the administrative costs that goes along with it. Essentially, it would take employers out of the business of providing health care for employees so they can do what their business is all about. It would simplify life for employers. It would reduce costs for employers. It would end job lock. A lot of people don't leave their job. They don't start their own business because they're afraid of losing their health insurance. So although there would be job loss from the insurance industry and administrative folks, there would be an increase of 200,000 jobs in New York State. It could be a magnet for business to come to New York. I think somebody mentioned this. Medicaid reimbursement is really, really low. Some doctors won't even see Medicaid patients. So now everybody would be in the same pool. So when you go to the doctor, you wouldn't be a Medicaid patient, you wouldn't be an Empire Plane patient, you wouldn't be a Medicare patient, you would be a patient. It would prevent 13,000 deaths in New York State. There is a net savings of $45 billion. That's $2,200 for every person in New York State. How would we pay for it? It establishes the New York Health Trust Fund, and in that fund, different monies would come into it. And so then if you go to the doctor, the hospital, they would just bill that fund. There would be a graduated progressive, this is based on ability to pay, a progressive graduated tax on taxable income from employment, an 80-20 split, which is pretty normal right now for our insurance. Unions could negotiate that differently. Employers could say, we're going to pay the whole thing. It's something like a Medicare tax. There would also be an assessment on gains, capital gains, interest, and dividends at the same rate. Federal funds now received from Medicare, Medicaid, Child Health Plus, the ACA, and other federal programs would go into that pool. We would seek waivers from the federal government to allow all that money to go into one pool as opposed to having all these little streams of money. Although the governor would present a revenue plan in his budget every year, just like he does anyway, that would explain, would show what those rates would be. But this Professor Gerald Friedman actually played around with some numbers, and he's suggesting a couple things. To exempt the first $25,000 from any assessment, and to have like a 9 to 16% assessment on our income. That 16% being for people who make $200,000 or more. So, if you believe we should try and protect New Yorkers from what may be happening at the federal level, and you believe that single payer is the way to go in New York State, the task at hand right now is to get this bill through the New York State Senate. So the first priority would be call your senator. Personal stories, I think somebody else mentioned this, personal stories are important. They actually can sway people's opinion on things. If you have friends or family in other parts of the state, call them, get them, encourage them to contact their state reps. And just because the focus right now is on the Senate, don't leave your assembly members out. They need to hear from you as well. So the contact information, I think it's back there for some. You can go to the Assembly website, the Senate website. It's on the Indivisible website. And I think there's now a little app on Facebook where you can just click and, yeah. I don't do Facebook, but it's there. One last thing, there's also another organization that's been working on single payer for many years here in New York. It's called the Campaign for New York Health. You may want to check out their website. So what I've done is over here on the table, there are, I think, 12 different handouts that you can sign up. I'll send you an electronic version. There's everything from fact sheets to a letter Barbara did, an op-ed that she did in 2014, the economic analysis. So all you have to do, put your name, your email, and just number what numbers you want sent to you, and I will do that. So thank you very much. I ran out of time.
Thank you very much. So much information and wisdom in this table. Let's give one more round of applause, please. Next we're going to take questions, and we have a mic so you guys can pass the mic around right there, or speak really loud. Some of you are loud, I know. And we have microphones back here to when people raise their hands.
My question is, what do the opponents of the single-payer program have in terms of their logic to oppose this bill? No logic?
You want to speak to?
Yeah. And do you have anything to say?
I'll throw something in.
Okay. Is this on?
Press the button.
Is this on now? Okay. Personally, I don't think Barbara's office has gotten a lot of opposition. I sometimes hear socialized medicine, that term, but this is not socialized medicine. Socialized medicine is when the doctors and the hospitals actually work for the government, as in the VA system. I sometimes hear that, it's going to increase taxes. But I think what I was trying to show is that it will add a tax based on ability to pay and your income. It also will tax the dividends and capital gains and all that. That's mostly high-income folks that are going to be paying that. The way we're paying for health care right now is regressive. It has nothing to do with your ability to pay. So folks who say, well, we're going to increase taxes, that tax will be a progressive tax based on ability to pay, and what we're doing now is not. Does that help?
I'm going to be really cautious from the chamber standpoint because we don't endorse one way or the other. We're simply here to help individuals with whatever plan happens to be out there. But I can tell you that there are people that disagree with the $45 billion in savings, and some people think it will actually cost more. So if you did some research, you would see a varying of opinions.
I think it's a matter of ideology, and oftentimes we get wrapped up in ideology, socialized medicine, as compared to actual facts. I do know that I'm also a small business executive. We have over 200 employees. We're a fairly decent-sized employer in this region. Under this type of single-payer system, I could give every one of my employees a $5,000 to $10,000 raise, which would more than offset any increased taxes that these individuals might pay. I think it's important to remember that when you pay for it up front, there is savings there.
Can I follow up on the single payer bill? If the bill goes through the Senate, will the governor sign it?
I don't know. I think the next step for all of us would be to make sure that the governor did sign it. Calls and emails and letters to him. We think he's running for president. And I think he listens to the public, and I think he sees that there is an increase in support for a single payer, both in the state and nationwide. But the governor doesn't talk to me on a daily basis.
Under the ACA, I think there are maybe 8 special essential services or conditions that are covered. I'm not sure what all 8 are. Would they be covered under the Trump Care bill? I've heard they haven't, would be, like maternity care and a couple others.
They're not required, Henry.
No.
They're not required. So
Yeah.
states can opt out of those coverages.
Even now?
No, under the new,
Under the new system,
Under
they could opt
AHCA.
out.
What are those?
I think they're listed on the back board there on one of the
Cancer,
maternity, mental health,
yeah, addiction.
cancer test.
mammography.
Preventive care.
There's a lot of preventive care.
Yeah.
So it's gonna be state by state, they could opt out.
So Barbara, what happens to the insurance companies in New York State?
I don't think it's going to eliminate insurance companies. It's just that they will not be selling health insurance, and not all health insurance. For instance, if somebody wanted to sell insurance for plastic surgery, just plastic surgery, non-medically necessary plastic surgery, then those products would be out there. But Professor Friedman's analysis shows that about 150,000 people would lose their job, both working in the insurance industry and all of the administrative folks that work in our hospitals and offices and stuff. But then we're going to create 200,000. And for a variety of reasons, one of which is there's going to be an increase in the utilization of healthcare. So there's going to be more jobs actually providing healthcare instead of administering health insurance.
Is that where the 200,000 jobs that you suggest are coming from? You said that there'd be 200,000 jobs created by the single payer plan?
Yeah, so this is Professor Friedman's analysis, and by the way, most of what his analysis and conclusions come from calling government statistics, and of course all the footnotes are there. But so some increase will become because there will be an increased demand for health care. The savings that employers realize, they can now spend more money on expanding their business instead of paying for health insurance or administering health insurance. So there's going to be a large savings, as Lisa suggested, for employers. Now, I suppose those employers could take that savings and pocket it, but we think otherwise. We think that it will be used to expand their business and hire employees. You know, by the way, you know, that economic analysis, it's really easy reading. It's actually not that wonky. There's nice charts, and it's just easy to read. I would suggest...
One's available to us?
Yes, and that's one of the handouts that's available, yes.
Okay, speaking of wonky, since Henry asked about the essential healthcare benefits under ACA, there are 10. So outpatient care, ER, inpatient care, prenatal, mental health and substance use, prescription drugs, labs, preventive services, pediatric services, and things like physical and occupational therapy, speech, so educational announcement.
Can you have a microphone and put
With the New York Care Act,
what if the companies like in multiple states, you know, they have private health insurance, but in your state they'd be mandated to.
Can you repeat that? I'm sorry, I was.
If a company's in many states.
Oh, okay, a multi-state company. Uh-huh.
Right.
Can you use that? Whoops, sorry. Yeah, so IBM probably is maybe a good example. So that company, if they have residents, employees in New York State, they would be paying that assessment for those employees. Employees in Colorado or Arizona or wherever, that whatever that state's laws are. So yes, they would only pay the assessment on New York State residents. Yeah. Does that answer your question?
Yeah.
Yeah, okay.
One question that really concerns me is one of the 10 items, which is the cost of prescription drugs and pharmaceuticals. Is there anything in any of the current legislative proposals to keep track, to maintain, to lower the costs of prescription drugs, to put some sort of damper on the profit-making of the pharmaceutical companies across the country, as is done in many of the European countries, where the government does, in a sense, negotiate for the price of drugs across the country, so there's an equity in what one pays for a prescription from New York to America.
New York State will be negotiating drug prices. And I think that might be one of the weaknesses. I don't believe that the Affordable Care Act required that, correct? Okay, okay, so that is still a problem with the ACA, is the price of drugs. But under the single payer system, New York State will be negotiating down the price of drugs and medical devices, yes.
I was wondering, for those of you in the medical field, what your opinion is of the New York Health Act, if you have any pros or cons?
That's a loaded question.
I'll just tell you a reality. The amount of time that my staff and our offices spend trying to figure out who's covering what when in terms of services, prescriptions, testing, is enormous. And if we had just one source that we could, oh, they cover this, now we know what the playing field looks like, that would save an immense amount of time, which could be used for better things such as care coordination or working with patients on doing self-management and things like that. Okay, we can take those dollars in terms of labor costs and put it to something useful. Okay.
Let the others.
All right, okay.
So at the hospital, we spend hundreds of thousands of dollars a year fighting to get what little money the insurance companies will pay us for all the work that we do. So whether we're trying to get pre-authorizations or they've paid us and 2 years later they take our money away and now we have to appeal and we have to file. We have to take physicians who have to spend time not with the patients but on the phone arguing with insurance companies, telling them why it was medically necessary to have that patient in the hospital, and really they weren't an observation patient, they really were an inpatient, and you know, it's ridiculous what we have to do to get your insurance carriers or Medicare to pay us. I guess though on the flip side, a single payer system, I guess I'd have to see what all is really going to be in there, because we technically had a single payer system back in the 90s for inpatients and things in New York, and it had issues with it, so I think it depends if it's, we really have to make sure that the hospitals and the doctors and the other providers are paid enough under that system to make sure we can really provide the services that our communities need. So there'd be a lot of negotiating, I'm sure, on how this would come out. The hospital association, or I'm sure be in discussions with the Assembly and the Senate. So I personally think we should have a single payer system across the country. I think the Medicare system is actually a pretty good system. They run very efficiently. They just have to add the benefits that they don't currently carry, like long-term care and babies and things like that. That's my personal opinion, so I think we need to get there, and I think New York probably will get there, hopefully fairly soon.
Yeah, I think just want to reiterate what Doug and Denise said. The amount of time and the amount of money that we spend trying to get your coverage paid for is unbelievable, especially when we're talking about psychotropic medications. We have specialized psychiatrists and psychiatric nurse practitioners that make decisions about drugs that are absolutely vital to keep someone stable in the community. And we have actuarial people who are making decisions about what they can take. Now, I know that that can't be right. We spend hundreds of dollars trying to make sure we can get psychotropic medications paid for to keep residents stable within our community. And it's a constant struggle.
I was thinking about this in terms of follow the money. And I think we have a tremendous inertia in the system in the profit that is attained through the insurance program and through the pharmaceutical industry. And until we figure out a way to control that profit-making process, we're going to have a tremendous inertia in the system. There's so many people who are benefiting from the tremendous income, this tremendous 30% overhead, that we have to find a way to appeal to their better selves, perhaps, whatever that might be, and move in a different direction.
So my question actually probably follows up on that relatively well. Are there any kind of stats or studies that discuss how much time, money, business growth is lost while we're all in limbo, waiting for the ACA, HACA discussions to kind of continue? Because I do think there's a lot of businesses, to your point earlier, that are saying, I can't grow, I can't expand, because I don't know if, how much cost I'm going to have to spend on my employees. So is there kind of stats to kind of talk about how much money is lost while we're kind of in limbo? Does that make sense?
We do know from Professor Friedman's study, we now spend, our employers spend $2 billion every year administering health care for their employees. We pay, and it's incorporated into the total cost of health care, $26.5 billion on private insurance administration. That's how much the insurance companies spend, and another $20 billion. This is what Lisa and Dave and Denise, or Doug and Denise, are talking about. $20.7 billion. So total, that is 20, 40, 60, $65 billion that everybody who has to deal with health insurance is dealing with. Is that, I'm not sure if that's your question though.
It's sort of, I think it's...
Yeah, and that's only going to get worse.
Well, and I guess the question is that if there are studies that then tie that to what businesses are not able to do, like hiring more staff, expanding their business, changing, launching new kind of offices because they're spending it on healthcare, or they're just saying, I have to hold this money,
right?
Because I don't know if next year at ACA, they're going to completely change how I have to pay people.
I don't think it's in Professor Friedman's study, but I could be wrong. But this is what I think we can do. Assemblymember Godfrey has spent 25 years working on this issue, and I have complete access to him. I can email him that and ask if there is a study that actually deals with that. So I could send that to you if you give me your email. Send it to you, Sue, as well.
Yeah, if you send it to Indivisible, we can put the information.
Okay. Okay. Yeah.
Not a study, but I can give you some testimonial. The three things we hear the most from small businesses, as you might imagine, taxes, regulations, and health insurance. And this has the ability to impact all three. And it could be great, but there's a lot of unknown out there. So people right now are going to be afraid to make many moves. I'll also point out that the Affordable Care Act, dealing with employers who have 50 full-time equivalents or less, are not required to do anything for health insurance. So if you hear of, and we have many of them here, small businesses who are providing health insurance, they're doing that on their own. There's no requirement for them to do that.
Any other questions?
Hi. One of the things that worries me about the proposed AHCA is that one of the things it says is it will no longer require employers with more than 50 employees to have coverage, to provide coverage, which right now is mandated under the ACA. As much as companies seem to be focused on spending less and less, cutting and cutting, is that something where we're going to go on a slippery slope and nobody will offer health insurance? My son, his company, and he's got a thriving company that he works for, he had insurance last year, his deductible was $250. This year, it's $6,000. In 1 year, from going from Excellus to United Healthcare, 1 year. And he's a truck driver, he needs help.
I do think that one of the things we've seen before the Affordable Care Act and continuing today is this issue around high deductible health care plans. Employers are choosing high deductible plans more and more frequently. The largest proportion of our population growing in our clinics are people with high deductible plans who cannot pay for their mental health services. That means they basically have to be offered our sliding scale fee. They have insurance, but they cannot afford to be seen by a mental health professional because of this issue. I think that employers are working very hard. I know my CFO and I struggle every year to try and find the best plans. We have platinum coverage. We feel it's very important for our employees because we can't pay them very well, that at least they have very good health care coverage. But not every employer has that leeway within their business model to be able to provide that. I do think, again, that single payer answers that problem. It means everyone gets coverage. And I wish we could look to our global partners, other countries that have implemented this well, alongside a thriving private insurance company model, and stop looking at ourselves as the sole individuals who have to figure this out. Other nations, despite the fact that, yes, they're smaller, have been able to accomplish this. And we are a nation of innovators. We're the smartest people in the room, or we often think so. Why can't we figure this out? Other nations have.
The hospital has seen, I would say, probably more in the last year and a half, more high deductible plans. I think the first year or so, we didn't really see that many in Cortland County. And what we saw happening last year was we definitely had a bump up in service in the last quarter of the year as they fulfilled their deductibles. Now they're all running in to get their stuff done before they hit January 1 and they all reset. So so you're stuck in the calendar year, right? So January 1st, we've got all these people coming in with Excellus and all these, and we're classifying it as insurance. And then we go and we bill it, and 30 days later, we're flipping it all over to private pay because they're all sitting in high deductible plans. So that's probably the first year we really saw the big push. So it's definitely happening. And personal note, United Healthcare is one of the worst insurance carriers to get paid from in Cortland County. So if you can talk your employers into dropping them, I'd love it because we fight every day to get paid by United Healthcare. They are not good to work with.
Do you know what the CFO, the Chief Executive Officer of United Healthcare makes a year?
Probably more than I do.
Last time I looked, it was 24 million.
Yeah. They don't like to pay claims.
Well, I like to, and I can't help but smile. Within the last 2 years, I've had to have a heart valve replaced and a triple bypass at the same time. And that wasn't near as hard to go through as it was all the insurances and medication and like that. And of course, you're on special medication when you're recuperating. And I love all my doctors, God bless them, I'll tell you. Well, anyway, I went to the Rite Aid where I buy all my drugs, and there's copay involved in everything. And I was paying, I think the top amount I've ever paid on any drug was $20. And I would have to pay as little as $3. Now I have United Healthcare, that's after my Medicare thing. And then I have, I think I went to the people here in Cortland, they do so well at the high school to help us older people out. Yeah, and I just love them. And I switched my drug coverage because I went to pick up my drugs as usual. And I love Sandy down there. She's wonderful. She could run that drugstore like anybody could. Well, anyway, so I gave her my slips and my coverage card, and she goes, $150 copay for one medication that I was paying $20 for. I said, oh, Sandy, I have 3, I even have Epic. You know, I tried to cover up, you know, because I really can't afford the, you know, health insurance. And I'm on the last few thousand of my retirement fund. I'm going to be 87 this summer. And I want to be as happy as I can. So. And anyway, and then when another one came due, and she said, we've got another one here for you, Rose. I said, okay, you know, save me a trip down. And that too was $150 copay. So that was $300 that I would never carry that amount. It's a good thing I have a credit card. God bless Chase, I'll tell you that. And, no, you're laughing, but I mean, I don't drink or smoke or carouse around. I don't have any fun. Thank goodness I have a lot of wonderful friends.
Do you have a question for the panel?
Pardon?
Do you have a question? Do you want a question to them?
No,
You let us
they
know.
seem to help me. They're working on all the problems. That's what I want them to do. I want them to get right at it. And I think we should have universal care for everybody. I don't care.
Right over here was do you still have a question?
Well, I was just going to say that our Senator Seward is the chairperson of the insurance committee, and I'm wondering.
Can you say that again, Andrea? I don't think everybody could hear you.
Okay. Our Senator Seward is the chairman of the insurance committee in the Senate, and so I'm a little concerned that it will never come. It has come out of healthcare committee and not the insurance committee.
Yeah, in the assembly it came through the health committee. Because it's really not an insurance plan. It's a health, so in the assembly it came through the health committee as opposed to the insurance company because it's not about insurance, it's about health care. Yeah.
Where does Seward stand on?
I just had one little thing to add. My methotrexate that I have to have for my rheumatoid arthritis went from $3 copay to $61. So you add that to the 300.
And I think we had a quick question. Do you know, Linda, where Senator Seward stands on the New York Health Act?
Where do his campaign contributions come from?
Right now there's 30 co-sponsors in the Senate. They're all Democrats.
Okay, so I think we're going to take one more question.
Yes, I just wanted to mention that I like what the doctor was saying about Colorado residents practicing healthy lifestyles. And I wanted to ask Linda if there's anything in that bill, the health bill, where there might be an incentive for healthcare providers to help young families work on those things, you know, starting out a healthy lifestyle for themselves and their kids, and also whether there's anything in that bill that would help. A lot of us see alternative health people, healers, along with our other health professionals, and that's becoming more and more popular. There's a lot of very professional, well-respected alternative healers in our area. Is there anything that covers that?
Thank you. The bill, when you start looking at the details, the way it's going to be administered and what its goals are, one of the things, there's going to be a board of trustees that include people from business, healthcare providers, labor, community advocates, blah, blah, blah. And then there's going to be regional councils. And their goals, just one of these, is they shall adopt community health improvement plans to promote healthcare access and quality in their regions. So the goal is to look at, I think everybody's been talking about this, that the cheapest, what we need to do and what we don't do well in this country is keeping people healthy. We're great when, you need a triple bypass or you've got cancer or whatever. We're really good at that. But we're not so good at actually keeping our communities healthy. And that is one of the goals. But you also asked about alternative. I didn't see anything specific on that. But I think what we do under this plan will develop over time. So those people who get involved in the councils and the board of trustees perhaps will, push for that. Did that answer your question? Yes. Okay.
Okay, so I would just like to say thank you one more time to our panelists. Give them a big round of applause. So we're going to wrap things up, and I wanted to say a few other thank yous. So first of all, a huge thank you to the United Presbyterian Church for continuing to host us and give us meeting space. And to Tom from the church, who's always great and comes and sets up our microphones and makes sure we've got all of our technical support. It's very, very much appreciated. I'd also like to thank the Indivisible Cortland County Healthcare Work Group. And when I call your name, if you're here, if you could please stand up so everyone who's here can see who put all the hard work into getting today going. So Sue Marks, Paula Davidson, Lisa Herschel, Anita Jebbett, Jana Adair Hansen, Kathy Homerhouse, Allison King, Clay Benedict, and Sheila Cohen, who wasn't able to be here today. And we have a few other people on the committee who have been helping virtually. I think, did I get everybody who's been at the meetings? I was making my list this morning. Okay. And I'm on the healthcare work group too. So just a big round of applause to all of us who put this together. I also just wanted to recognize the Indivisible Cortland County Steering Committee. These folks are helping behind the scenes, both with the monthly forums and the website and Facebook and e-blast and lots of other activities in the community. And we have a steering committee member on at least one on all of the different work groups that we have. So I think we're about half here, half not. So when I call your name again, if you could stand up so people know who you are. Paula Davidson, Margaret Little, Randy Ross, Kristen Avery, Laura Seib, and Jane Hall. And I'm also on the steering committee. And absent today, but also very much helpful to the committee, is Priscilla Bergen-Thomas, Maria Hopko, Sarah Young, and Gail Bundy. So without those folks, none of this would be happening. So thank you very much. So I know we've mentioned the healthcare work group several times today. We have topical work groups, and if you weren't familiar and you're interested in getting involved, over against the wall on the benches, there are signs for all of the different work groups: healthcare, education, immigration. I won't list them all, but if you're interested, sign up, give us your contact information, and the work group will get in touch. There's also just a general sign-up sheet for Indivisible Cortland County. So if you're not already receiving our emails and you'd like to, or if you want to make sure that you're notified when we're having events, go ahead and sign up on that sheet as well. And on the table over here, there's just a wide variety of information about help if you're trying to call your representatives or write emails or letters. There are business cards for Indivisible Cortland County that have our email and our website and Facebook and Twitter information. On the table where Randy is, he's holding up the sign-up sheet. Linda Smith referenced several times the study that has all these statistics in it, which I believe you said number 11, is that right?
Number 11.
So there's a lot of handouts on the table where Randy's sitting, and they're all numbered. If you would like Linda's office, Assemblywoman Lifton's office, to email you any of those, just sign up on the list and which numbers you want, and she's agreed to do that for us. At the back of the room, there's a couple of display boards with information on the healthcare legislation, and right in the middle, we thought at every meeting we try to do an activity, like we ask you to take some kind of action. So obviously we focused a lot of today's agenda talking about the New York Health Act. So although we don't know 100% sure what Senator Seward's stance on that is, if you live in Cortland County, he's your senator. So we've got index cards at the back of the room and pens and just a sample. So if you could write a little note to him, personal stories are great about something that is of concern to you or extreme importance to you regarding healthcare and how you would like him to vote on the New York Health Act. And if you put it in the wicker basket back there, we are happy to deliver those to Senator Seward's office so he hears from all of us what we think. Were you going to say something about that, Vivian?
When I called Senator Seward's office last week, the staffer said they didn't know where he stood on it and they'd get back to me, and I haven't heard yet.
Okay, so for those of you that maybe didn't hear that, she did call his office and they said they weren't sure and they would get back to her, and she hasn't heard anything yet. So I also would just like to point out, we've been doing these monthly meetings that are topical. Next month is going to be a little different. We'll be back here on June 17th. Instead of having a speaker, it's going to be an interactive training. It's called Bystander Intervention Training. So if you're interested in participating in that, it's going to be at about a 90-minute training. There's a poster on the back table that gives some information, and we'll make sure more information goes out about that in our e-blast and on the website as well. So that's the format for next month. And I'd just like to thank everyone again for coming and for donating to the food drive. And we encourage you to stay, have refreshments, chat with any of our presenters who are able to stay after for a little bit. But we really, one more question?
I want to commend the panel. This was outstanding.
Thank you, Noah. Yeah, one more round of applause for the panel.